I'm going to be introducing our final speaker today, and I think you've all been waiting very patiently to hear all about GLP-1 antagonists and what we do with them in our patient population. So our next speaker is Dr. Suman Srinivasa, who is an assistant professor of medicine and assistant director of the Master of Medical Sciences in Clinical Investigation at Harvard Medical School. She's also the co-director of the Miracles program, which stands for Metabolic Investigations, Researching Adipose and Cardiovascular Health. So that is in the Metabolic Unit and Division of Endocrinology at Mass General Hospital. Her clinical research has concentrated on investigating the contribution of hormonal systems to fat redistribution, accumulation, and ensuing inflammation and cardiometabolic disease in people with HIV. And she's going to talk to us this afternoon about weighing in on GLP-1 receptor agonists for people with HIV.
Hi, everyone. I'm delighted to be here today. Thank you to the organizers. So we're going to be talking about GLP-1 RAs. You may have heard of them. And if not, I think today, Drs. Wooten, Aberg, Dar, and Badimo all provided the perfect segue to our talk today. All right, so our learning objectives are shown here, and really we're going to set the context for these medications in terms of what is known in the general population, and then we'll turn to what is known in HIV. And we heard some of this earlier today, but by way of background, just as a refresher, we know that weight gain has been associated with ART initiation and generally does not improve with ART switch, and really large studies have taught us a lot about this. And with regards to ART initiation, the RCTs have shown higher weight gain in those receiving INSTI or TAF-containing regimens when compared to those receiving TDF, abacavir, or zivudine. And in terms of the INSTIs, dolutegravir and bictegravir have been most consistently implicated with weight gain. And with regards to ART switch studies, the RCTs demonstrate moderate weight gain, and those switched off of efavirenz and TDF had the greatest weight gain. And again, as we heard earlier, this really needs to be discerned further in terms of whether this is actually weight gain or if this is secondary to TDF being weight suppressive. And additional risk factors for weight gain include women with HIV, low CD4 count, high viral load, as well as black race. Of course, there are consequences to weight gain. So in this study, individuals on ART were shown to gain about 3.6 kilograms for the duration of the study. And those that had greater than 10% of their weight gain had a twofold increased risk of diabetes and metabolic syndrome, and a 1.5 increased risk of a cardiometabolic event. And complementary to this, the participants that lost about 5% of their body weight actually had a lower rate of metabolic syndrome. And this really highlights the fact that it is important, weight loss is important. And greater weight loss leads to increased metabolic benefits. So you can see here with just 5% of body weight loss, that leads to improvements in hypertension as well as hyperglycemia. With 5 to 10% of body weight loss, that can lead to prevention of diabetes. And as we got a primer earlier before, improvement in fatty liver, now known as MASLD, and also an improvement in dyslipidemia. With 10 to 15% body weight loss, we can get improvements in heart disease as well as steatohepatitis. And finally, when there is greater than 15% weight gain, that can really lead to remission of diabetes and actually reduce CVD mortality. All right, so let's pause and turn to our first question. Let's get an idea of how many of you have had experience with these medications. So have you ever prescribed a GLP-1 RA? Waiting for a couple more votes to come in. Oh, wow. So half and half. So that's great. Okay. Changing a little bit there. Okay. And our next question, so if you have ever prescribed a GLP-1RA, what was the indication? Was it diabetes, weight gain, both diabetes and weight gain, something else, or I have not prescribed a GLP-1RA? All right, great. Getting a lot of ties on these answers. So, it seems like about a quarter of you prescribe them for diabetes and weight gain, and a third, apologies, maybe not have prescribed them before. All right, so glucagon-like peptide 1, or GLP-1, is an incretin hormone. It's secreted from the small intestine following food ingestion, and it acts to stimulate insulin secretion as well as inhibit glucagon release, thereby leading to its glucose-lowering effects. And the GLP-1RAs, these medications, mimic physiologic GLP-1. And based on these mechanisms, these medications were leveraged for their use in diabetes. And unexpectedly, when studied in diabetes, these medicines happen to show a really significant amount of weight loss. And they were then more directly assessed for their benefit on weight. The GLP-1RAs also work on the brain to suppress appetite and work in the stomach to slow gastric emptying. Both of these lead to increased satiety, and these are probably the mechanisms of which account for their weight loss. There are GLP-1 receptors found all over the body, in fact, and so there's thought to be broad potential action to these medications that may extend beyond the heart, to the heart, kidney, liver, fat. The list goes on and on here. So that's why these medicines are thought to be quite appealing. All right, so listed here are the GLP-1 RA preparations, and you may be familiar with semaglutide, liraglutide, and dulaglutide. So the majority of these are subcutaneous injections. The only exception to this being there is an oral form of semaglutide, but this is only indicated for diabetes. What you'll see here is that only semaglutide and liraglutide are indicated for weight loss. Semaglutide is given once weekly, liraglutide is given daily, and you'll see here that they are marketed under different names based on the indication, so you'll just need to be careful when prescribing these. And actually for weight loss, they can be given at higher doses as well. All right, so what about the efficacy on these medications? What have we learned about using these medications in diabetes? And so what you'll see here is that in general, across all of the formulations here, there's about a 1 to 1.5 point decrease in A1C, and probably as high as 2 points with semaglutide. And based on concerns of older diabetes medications, namely rosiglitazone, which has been linked to actually increased cardiovascular disease and risk. The FDA now mandates that large cardiovascular outcome trials are performed for all new diabetes therapies, and these were typically designed as non-inferiority trials. So along the way of doing these for these medications, there was actually an unexpected reduction in cardiovascular mortality in the patients in these trials. And the nuance here is that they enrolled participants with existing cardiovascular disease. So we do not yet know how the cardiovascular mortality benefit extends to those who do not have known cardiovascular disease or are low risk. These medications also have nephropathy benefit as well. All right, so what about the efficacy on weight loss? So the STEP 8 trial allowed us to understand this further, studying only those who were overweight or obese, and they excluded individuals with diabetes. And they studied the 2 medications that are currently approved for weight loss, semaglutide and liraglutide. And what you can see here is that semaglutide offered about a 2 to 2.5-fold increased risk of weight loss when compared to liraglutide, about 16% versus 6% as shown in the graph. And what they also saw was that there were greater proportions of weight loss with semaglutide with increasing doses as well. And so in this way, we think of semaglutide as more robust for weight loss than liraglutide. All right, and just to sort of set the context of these medications, you can see here that semaglutide offers more weight loss benefit when compared to older weight loss medications that we had available to us. I've also listed here tirzepatide, which is a dual agonist GLP-1, and we'll touch upon that a little later in the talk, but just to get an idea of the comparison. And by far, amongst all of these, you'll see that with gastric bypass, you can achieve the most weight loss. As we see, sleeve gastrectomy offers about a 25% weight loss benefit. All right, so I showed you data, or I showed you sort of indications in terms of the diabetes trials and that there's improved cardiovascular mortality. So the SELECT trial went on to assess these cardiovascular outcomes in obesity among those without diabetes, and Dr. Aberg also referred to this data as well. And so in this trial, they enrolled individuals with a BMI above 27. They did also have pre-existing CVD, no known diabetes though. Their primary endpoint was looking at composite death from cardiovascular causes, non-fatal MI, or non-fatal stroke. And what they saw was that there was a 20% risk reduction in cardiovascular, in their cardiovascular endpoint with the subcutaneous semaglutide. And so this is really impressive here that you have a medication that has dual effects to both decrease weight and also contribute to reducing cardiovascular mortality. Now, again, the nuance here again is we yet don't know how this extends to individuals that don't have a known history of cardiovascular disease. And this is important for us to study, especially in our population, whom we know, as we've seen today in just the talk prior, have an increased risk of subclinical cardiovascular disease. All right, so based on the studies that I've showed you thus far, the current clinical indications were derived. So an important note is that these are not to be used in patients with type 1 diabetes where the pathophysiology is insulin deficiency versus in type 2 diabetes where the pathophysiology is insulin resistance. So with regards to type 2 diabetes, these can be used with those with established ASCVD or kidney disease. It can be used in those without ASCVD or kidney disease when the A1C is greater than 9, or when the A1C is less than 9, but there is concern for weight gain. With regards to obesity specifically, these medications can be used in those with a BMI above 30, or if the BMI is above 27 and there's a weight-related comorbidity as well, and it is expected that before patients go on these medications that they've failed a comprehensive lifestyle program. And just recently, in March, the FDA, based on the data from the SELECT trial, now extended semaglutide use to those with pre-existing cardiovascular disease. And hopefully this will, extend approval for these medications, which has been so difficult for us to get for our patients. All right, with regards to side effects, so injection site reactions, as with any subcutaneous injection, it's important to note the risk of hypoglycemia is actually quite low and typically may only occur when there's use of another anti-diabetic medication, namely insulin. The side effect that really precludes patients from tolerating these medicines are the gastrointestinal side effects, which extends to nausea, vomiting, diarrhea, and even constipation, which I don't have listed here. We tend not to use these medications in those that have a history of pancreatitis, though there's newer data coming out suggesting that it shouldn't necessarily be a strict contraindication. There's also a risk of biliary disease. Acute renal insufficiency has been described, but it's really quite rare and mostly probably secondary to those having GI side effects. And there is a black box warning for medullary thyroid cancer. Its use is contraindicated in those with a personal and family history, and this was mainly derived from rodent studies. So there are suggested dosing recommendations, as shown here. And really the ideal clinical strategy is start low, go slow. So you really want to delay dose escalation if the patient can't tolerate it due to the side effects. And that's because if they are having GI side effects, it's possible that with some time and use of the medication that those symptoms will essentially subside. So if there's several missed doses or preparations are being switched between one another, you may also need to restart the low dose to avoid these side effects. And keep in mind the maintenance dose may be the submaximal dosing for some individuals. You don't necessarily need to push it to the max. The goal here really is to achieve the greatest weight loss while avoiding side effects. And also, in the past year, the American Society of Anesthesiologists released a consensus statement, and it's acknowledged that these medications need to be held in the peri-op or peri-procedural period if anyone is undergoing anesthesia or procedural sedation. And this is really to avoid aspiration events and aspiration pneumonia. The studies have showed, just based on its mechanism of reducing gastric emptying, that they have about a 30% increased residual gastric contents compared to those not using these medications. It's recommended that prior to a procedure that the weekly dosings are held for a week, the daily dosing just hold the day of. And you may have to also counsel your patient on longer fasting periods prior to surgery when compared to usual. So aside from medullary thyroid cancer, there has been some potential concerns about malignancy, but this study, which mined the FDA AE reporting database, really showed that there was not a disproportionate increased risk of other malignancies. In addition, the FDA has conducted studies looking into the association to suicidal and self-injurious behaviors, and that's because the Icelandic Medicine Agency reported about 150 cases of GLP-1 RA and associations with these behaviors, which then prompted the European Medicines Agency to perform an investigation as well. And several reports have been released, and overall it is noted that there's no disproportionate reporting of an association between these behaviors and the GLP-1 RAs. So it's really thought that perhaps we were seeing these associations because chronic medical conditions such as obesity may be a comorbidity, and these behaviors may be comorbidities of each other, and they may be occurring regardless of the medications. So even though we did not see this association, it's still very important that you counsel your patients and that they're just talking to you about whether there's any change in symptoms that they're having. All right, so the combination GLP-1s are rapidly evolving, and while not the focus of today's talk, it's important that you are familiar with them. So here we have tirzepatide. It's a dual agonist. It's a GLP-1 combo GIP, glucose-dependent insulinotropic polypeptide. It's really thought by using multiple gut hormones that you can get synergistic actions of these medications. As shown here on the right, the GIP has similar actions to the GLP-1 in that it increases appetite, but some of its actions otherwise differ. Nonetheless, it is thought to be beneficial, and the tirzepatide was approved for use in type 2 diabetes as well as obesity, and in fact it does have a more robust effect on A1C and mean body weight loss as well compared to the single agents. All right, so one clinical question that always comes up is, are these chronic medications? And this is an important point. So in this study, participants were on lead-in tirzepatide, and then following that lead-in period, either the tirzepatide was continued or it was withdrawn and they were placed on placebo. And what they saw here was that there was substantial weight regain once for the patients that were on placebo. They gained about 14% of their body weight. So this is another point that needs to come up in discussion with your patients when discussing these medications. Another clinical challenge is that there's these medications may be related to tachyphylaxis, and that these patients may develop a tolerance to the medication as well. All right, so when thinking about weight gain, we really need to discern between different adipose tissues. So subcutaneous adipose tissue, or SAT, is thought of as the pinchable type of fat. You do need some subcutaneous adipose tissue because that is where you need to store your triglycerides. And this becomes an issue whenever you have too little SAT or too much SAT. So when there is a lack of SAT, as in lipoatrophy, or when there is excess SAT and it's dysfunctional, as in obesity, you have nowhere to store your triglycerides, and the triglycerides then overflow into the visceral adipose tissue. The VAT is in your abdomen and in and around your organs, and it is a highly inflamed fat that is related to metabolic consequences. So as shown here on the right, with lipodystrophy, in which the phenotype is high VAT, low SAT, the ideal clinical strategy would be to reduce VAT and preserve SAT. In this regard, there is an FDA-approved medication, tesamorelin, which is a growth hormone-releasing hormone analog, and it does just that. It reduces VAT, but it preferentially preserves SAT. Now, in obesity, we think of this as a high VAT, high SAT phenotype. And so the ideal clinical strategy is to reduce VAT and SAT, and in this regard, the GLP-1 might be particularly attractive. All right, so when we think about weight loss, we also want to think about the different components of body composition that are being affected, namely the fat versus lean mass. And as we heard earlier, again, as persons with HIV are aging, there's an increased risk of frailty, and sarcopenia, which is age-related loss of muscle strength and function, can contribute to frailty and is almost 6-fold higher among persons with HIV. So this is really a critical issue, and the ideal clinical strategy in this scenario would be to preserve lean body mass. So we have studies that have helped us understand how the body composition is being affected. So in the STEP 1 trial, using the subcutaneous semaglutide, when they broke it down and looked at different body composition, there was about a 19% loss of fat mass. In terms of visceral fat, 27% was lost, and then about 10% of the total lean body mass. And just to place that in context, this lean body mass that was lost with the GLP-1 was about 40% of the total weight loss. And we all lose about 5% of lean mass every decade, just in general. And other weight loss medications do also contribute to lean muscle loss, but the average is more around 25 to 30%. So it's really maybe the rapidity and the amount of lean muscle mass that's lost here that is quite concerning. Now, one nuance here actually is that when they looked at the ratio of lean body mass to total body mass, this actually increased by 3 percentage points. So while there is lean mass loss, it's disproportionately lower to the amount of fat mass lost. All right, so now let's turn to data, what's known among persons with HIV. So this was a retrospective study assessing the impact of GLP-1R initiation. This was led by Dr. Woon's group. It was a large study of over 200 participants. Over half had diabetes. And what you can see here is that in general, there was about 5 kilograms of weight loss, about a 2-point reduction in BMI, and the mean A1C went down by a 0.6 points. So I think the full potential perhaps of the medications aren't realized here because only 38% of participants achieved maximal dosing on the medication. They also looked at factors that could be associated with weight gain, and they saw that these included higher BMI as well as a longer duration of treatment. This was an observational study from the Scenics cohort assessing the impact of semaglutide amongst individuals engaged in clinical care over a year. And similarly, they saw about an absolute reduction of 6.5 kilograms of weight loss, which was about 5.7% body weight loss. And on the right here, you'll see that with increasing BMI class, there tended to be more weight loss. Now, this study assessed the impact of these medications amongst those with diabetes, with or without HIV. This was a small study of about 45 participants, and what they saw was that there was greater mean weight change and loss amongst those with diabetes and HIV. You can see here they lost about 10 kilograms and 8% body weight loss compared to those with diabetes, which was much smaller, but you can see here the standard deviations are quite large. There was also, there tended to be a higher reduction in A1C as well amongst those with diabetes and HIV. So this starts to suggest that there may be increased efficacy of these medications in HIV, but really further studies are needed for us to understand this further. All right, and this was data presented by Grace McComsey at ID Week, and this was the first randomized double-blinded placebo-controlled trial of semaglutide, so it's really quite exciting to see these results. They used a low dose of semaglutide at 1 milligram, and the max dosing for weight loss is 2.4, just to remind you, and this was over 24 weeks. They enrolled individuals with a BMI over 25 with increased waist circumference, and they were really selecting here for a phenotype with lipohypertrophy. On the right here, you'll see the results. When they looked at the VAT and SAT, semaglutide decreased the VAT by 13%, while it increased 5% in placebo. With regards to SAT, there was a 13% reduction in VAT and a 1.5% increase with placebo. They then further went on to look at the total fat and total lean mass loss here, and you can see there was reductions in both depots. And again, what they saw here again was that while there was some lean mass loss, it was proportionately lower to the fat mass, and so there was a net effect of fat mass loss. And overall, it was nice to see that there was excellent adherence. The AEs were similar between groups, and it was well tolerated. This group also went on to show secondary data looking at inflammation with semaglutide, and what they saw was an overwhelmingly significant reduction in CRP, IL-6, and CD163, and these reductions were independent of changes in VAT and weight, and so this starts to suggest that there might be some anti-inflammatory potential to these medications, which again is quite exciting, especially as we just heard about inflamma-aging. All right, and we heard about the slim liver study earlier, but again, this was a really exciting study looking at semaglutide on Mazold. This was an ACTG study, open label, performed over 24 weeks, again using a low dose of 1.0 milligrams. These individuals were on ART, they had an elevated waist circumference, they had insulin resistance or diabetes, and at baseline they had an intrahepatic triglyceride content greater than 5% on MRI, that latter criteria being important because that is diagnostic of fatty liver disease. And what you can see here was they saw a very nice reduction, absolute reduction in the intrahepatic triglyceride content of 4% and a relative reduction of about 31%. Almost a third of these participants had resolution of Mazold, and these improvements in triglyceride content were correlated with weight loss and also accompanied and correlated with significant reductions in glucose, insulin resistance, A1C, and triglycerides. They also presented secondary data from the slim liver study looking at muscle structure and function, which we reviewed was quite important to learn about. And they assessed the psoas muscle, which is important to posture as well as strength in the proximal leg there. And what they saw was that semaglutide does reduce psoas volume, and the decline tends to be greater amongst those that are greater than 60, so that's a little bit concerning. There's no reduction in psoas fat. However, when they looked at function, they assessed chair raise time and gait speed, and these were preserved or tended to improve despite the muscle loss that we saw. So here we see a little discordance where there is perhaps an effect of these medications on structure, but you may have preservation of function. So, we don't know sort of whether these are that detrimental to the muscle compartment. But these studies start to give us a little insight into this, and more information is needed, of course. All right, potential interactions. So these medications are not expected to pose any significant drug interactions via their metabolism because they're degraded by endopeptidases. As we learned earlier, they inhibit gastric acid secretion and delay gastric emptying. And so this may come up with atazanavir as well as oral ripivirine, which may be affected by elevated gastric pH, though these really thought to have a minimal effect here with the interaction. It's perhaps suggested that the orally administered GLP-1 is separated by 4 hours from these medications. All right, and then in terms of the benefits, they just continue to be explored. So heart failure with preserved ejection fraction, or HFpEF, is increased in prevalence in obesity. And we do know that individuals with HIV have an increased risk of subclinical myocardial dysfunction as well, which could lead to HFpEF. So in the STEP-HFpEF trial, evaluating those with HFpEF and obesity, the semaglutide was shown to reduce symptoms and physical limitations, as well as show greater improvements in exercise function. Now, it's important to note that these are just preliminary studies. We really don't know how this affects more sort of events and endpoints like hospitalizations from heart failure. With regard to addictive disorders, we do know that GLP-1 receptors are found in areas of the brain that are relevant to reward and addiction. And so preclinical research has identified potent reductions in substance use and the attenuation of drug-seeking behaviors. And this is, again, mainly in rodent models. There's been few limited studies performed. There was one clinical study of individuals with alcohol use disorder, and what they did see was that alcohol use consumption reduced in a subset that had obesity. So there may be some pathophysiological links to weight gain and obesity. But again, we really need rigorous studies to understand this further and see if there are actually benefits. And additionally, there have been studies amongst those with diabetes, which may suggest that there's improvements in cognitive decline as well as memory score. But this is really in its infancy as well, and we need to understand whether these medications may have improvements on neurocognitive disease as well. All right, so with that, I'd like to just summarize our take-home points from today. So GLP-1RAs are effective therapies for weight loss. Semaglutide appears to have the most robust effect on weight loss. The GLP-1RAs have broad effects on body composition, so you're losing visceral fat, you're losing subcutaneous fat, and it's also reducing lean body mass. Now, just to remind everyone, lean body mass is everything but fat, so it includes muscle plus other things. And we also know that GLP-1RAs reduce cardiovascular outcomes in obesity amongst those with known cardiovascular disease. A reminder that we just need to understand these further in those that are lower risk and have no absence of heart disease. And the RCT of the GLP-1RAs amongst persons with HIV have shown a significant effect on body composition that's beneficial. And preliminary studies also suggest a benefit to liver fat and inflammation. These were open label studies, and these really deserve further investigation, though, but it's quite exciting. And there may be other potential benefits, as I noted on the last slide there, that need to be tested as well. And we sort of talked about some of the clinical concerns with these medications as well, and that extends to the chronic use of these medications, and that you can have weight regain after they're withdrawn. We highlighted the loss of muscle mass with these medications, and there may be issues with tolerance, as well as aspiration risk with anesthesia and sedation. So with that, I'd like to take any questions.
Wonderful, wonderful. Hi,
Hey, Paul.
later.
All right.
I just wanted to say that everyone was really good, and you came forward and sat in the front when I asked you to. That was great. I don't know if you've noticed that the front has been gradually emptying. One by one, my friends have gone off to O'Hare. And so the question, and this is either I'm just a nerd or everyone knows this, but why is it ORD? Do people know that? Yeah, everyone knows it, I guess. All right, I thought I was the only one. Go ahead, yeah.
Thank you. Great talk. Both you and Roger sort of referred to loss of lean mass as of concern and somehow linked it to frailty. And I kind of want to push back, but maybe I don't know. I don't know of any data that shows that loss of lean mass in addition, along with fat, is anything but good. The data is that if you lose 20% of your body weight, all of those markers get better. And that when you, as you said, when they talk about lean mass, very few people are measuring muscle. It's also water and bone and who knows, brain, whatever else you're losing. And I don't know of any data that shows that that's linked to frailty, that that's a bad thing. That happens anytime you restrict calories and lose weight and don't exercise, which we've been telling people to do for decades, and we finally got something that does it. This is really on the web a lot, and it kind of sounds like finger wagging. Like, you know, if you use this stuff, you're just going to get tolerant, and you're going to lose all this lean muscle mass, and you know, because you're not going to be the big beef, whatever. Is there any data to show that this means anything because everybody's talking about
So
it?
you're saying we'll stay strong but be stupid? No, I'm kidding.
Right. Okay. So thank you. So I think that's a really important point, that we do worry about lean muscle mass, but what does this actually clinically translate to? And I think yes, you're correct. We don't actually understand if this is detrimental. And I think that data from the slim liver studies was important to begin to think about this, because it's trying to understand, if you're losing volume, is that actually leading to detrimental effects? And it may not be if your function is preserved. And like you said, maybe it's just a composite of losing all body weight. And yeah, I think this definitely needs to be sort of, elucidated on further. I think one of the worrisome things is that it does seem to be proportionately more than other weight loss strategies. So how that differs, I don't think we understand those effects right now, but people are actively studying this now to understand how much should we be counseling our patients on this. I think in clinical practice right now, we are sort of emphasizing resistance training with our patients, and I think we'll maybe understand some more of this also, because there's a lot of activity going on about understanding, like, do we need to give something with a GLP-1 to preserve muscle, and will that have any benefits? People are looking at myostatin inhibitors and other things like that. So again, I think we're just sort of clinically conscious of it, but again, how does this translate? Just like we would look at a cardiovascular trial, and we'd want to know, is this preventing events? So what is the endpoint like in terms of losing this muscle mass? So thank you for bringing that up. Yeah.
Good, really good question. So a question from the audience was an interesting one for those of us that have been around a long time and can remember the really horrible lipodystrophy that we saw. Any sense of whether these drugs have any effect on that phenotype in some of our older patients?
Yeah, so I think one thing that we want to exercise caution with in using these in lipodystrophy is where on the spectrum of lipodystrophy is the patient. Is there evidence of lipoatrophy? And I wanted to highlight that sort of when I was talking about the different adipose depots, in that this could potentially have some deleterious effects, because you don't want to reduce the SAT depot further in someone that has lipoatrophy. Now, I know we see less and less of that current day, but that may be a particular phenotype where you may exercise caution, because again, the danger is that the more you lose whatever SAT you have, the more VAT accumulation you're going to have. And although you're going to get some VAT reduction with these medications, what is the net effect and net benefit? Because increased VAT is linked to diabetes, cardiovascular disease, many metabolic diseases. So that may be one sort of a consideration to take into place. Now, if there, and again, we don't have great ways in clinic, unfortunately, to measure SAT and VAT. So that's, the gold standard is imaging using CT and MRI. DEXA can be used, but not typically through the DEXA that you obtain for bone density, but can be used for research purposes to give us an idea of VAT, SAT, and lean mass. But based on clinical exam, if there is evidence of subcutaneous fat and also lipohypertrophy, you may consider using a GLP-1 in this case. There are just very few. So aside from lipodystrophy associated with HIV, there are congenital lipodystrophies. So if we just use that as an example, there's just very few data. There's a very small study on the order of like 10 patients where they looked at using GLP-1s, and they actually thought it was beneficial. So I think we still need to understand this also a little further.
So another question, how about insurance coverage? If a patient best tolerates a somewhat lower than maximal dosage, or do you have trouble getting insurance to cover these drugs for that kind of patient?
Yeah, so I think insurance approval has just been very difficult for weight loss. Diabetes is typically, not a problem, but for weight, definitely. I think the dosing is really not the issue in my sort of perspective in terms of getting the medication approval. It's really just even getting the low dose for these patients. And it's more of a supply issue, I think, in terms of dosing and right now, there's just a supply and demand issue, of course, as you all know. So it's really what the patient can get their hands on right now.
So I think it was at Croy when Charlie Flexner gave a talk, he referred to a boosting drug, cobicistat, and I went, what? Because I'd always called it cobicistat. And really at this meeting, I've learned that I've been saying semaglutide, which is apparently not right.
You say tomato, I say tomato, okay. So it's fine.
We'll have potatoes for dinner. Thanks, and I should acknowledge you have a Northwestern Evanston presence as well in your history.
I have a UIC presence.
Great.
Yeah.